My name is Michael Vitale, and I'm the president and founder of the Fatty Liver Alliance. Today, I want to welcome two incredible guests and a brand new topic to discuss. Mark Swain, hepatologist and professor of medicine from the University of Calgary in Alberta, Canada, and Mazen Noureddin, who was the founding director of the Fatty Liver Program at Cedars-Sinai Medical Center. He recently relocated to Texas from California to establish a state-of-the-art Houston Research Institute. He's an expert in non-invasive testing and biomarkers of NASH and cirrhosis. Mazen, you recently published a very important and insightful paper about machine learning and the ability to predict severe liver disease. This is incredible, and many would say breakthrough. What's machine learning, and how can it help us with identifying patients who have severe liver disease and the risks for progression?
Thank you, Michael. It's great to be here with you and friends. And I'm glad that you like this paper. We started thinking about it actually a couple of years ago, especially in the field of hepatology. You have seen machine learning and the AI technologies in other fields, and in the field of hepatology, mainly in pathology, which is great to have. But also machine learning can do multiple things, and one of them is disease prediction. And that's what we did. We had a very large cohort, or we collected a very large cohort of patients, 1,300 with paired biopsy. So this is actually one of the largest cohort out there with paired biopsy within the 6 months. It was just a collection of multiple medical centers that we put in one pod. And to answer your question, as I start, before I go into details, it's the computers and softwares and machine learning and AI, what they do is they go and see your data and start analyzing it. And the way I want to put it is they're smart ways to make things perfect in terms of prediction. And that's why a lot of times, which happened in this paper and some New England journals paper, you don't see the testing cohort, you just see the validation cohort. The reason why you don't see the testing cohort, because what machine learnings do, if they want to predict, let's say, F2 patients, and the testing cohort, the area under the curve can go as close to 1, because the softwares are seeing all variables and seeing the outcome and just do kind of like this first look and make it as perfect as possible. And then you go validate it in a subsequent test, which is the validation test, and you look at your area under the curve, sensitivity, specificity, MPV, PPV. So yeah, that was an effort to, now we have multiple non-invasive testing, but the question was simple. Can we take the patient's variables and do as well as FIB4, FibroScan, that's what we had in the cohort, or do even better because of this ability for the machines that is close to perfection nowadays.
I think your hypothesis was as bold as to say that it could possibly replace biopsy too, right?
I mean, yeah, it's a biopsy is the bad guy. Everyone can criticize biopsy, and poor biopsy, you win at the end. But no, I mean, listen, like I was trained by pathologist David Kleiner in particular, and I still think it has a great role here and there. We just want to go past the biopsy once we can, in a disease that's so prevalent in the world that it's probably incorrect to do it on that many people, especially like when you start talking about follow-ups over years. So yeah, it did better than biopsy, and we're happy to go to more details, and did better than non-invasive testings as well.
Well, I was wondering too, and I'm sure Mark has questions he's busting to ask you as well. But is this something that's ready for use in the in the physician world? Is it still early?
It's interesting you asked this. So one of the things that I guess people have to have a little bit futuristic look. the machine learnings the model that we came out had 17 variables. So the nice thing about these 17 variables that they are all available in clinic, that they're routinely done. And we get a comment from one of the reviewers like 17 variables, what do I do with it? Although this is what we think the future with machine learning, you're not supposed to do it. Neither Michael nor Mark just start punching 17 variables numbers, spits out the number at the end. This is supposed to be in another machine, meaning apps. Or Epic, for instance, they should spit it out for you and tell you the risk and the score, and that's where we see it going. So yeah, there are steps being taken now to apply it in certain applications, certain apps, but it will be in a large health system as well as a big app that can come to your clinic and do it for you. Don't forget, it has all the predictions that imaging machine do, not your regular non-invasive testing. For instance, F2 and I'm sorry, FIB4 and NAFLD fibrosis score, technically they test F3 and higher. That's what they do. ELF does test two cutoffs, one predicts cirrhosis, one predicts decompensation. Versus FibroScan, for instance, will test F0 through F4, and with the FAST score, you will test NASH and F2. These models we have, they tested F2, F3, and F4, as well as NASH and F2 and higher, which is the group that they're going to have therapies at the end, and predicted all of them well and better than the FIB4 NAFLD fibrosis score and the FAST score. And the area under the curve was 0.86 for F2, 0.89 for F3, I think, 0.89 for cirrhosis, and 0.8 for NASH and NASH and F2 and higher.
Yeah, Mark, how do you see this in your clinic situation, if that would be possible one day?
Well, I mean, I agree completely with Mazen. I mean, things have to go away from the way we're traditionally doing it. And there's a couple shortcomings in how we do things now. And one is that a lot of what we do is based on a decision by a primary care physician to refer somebody, and that often is based on abnormal liver tests or just some variable that they might be interested in following and typically follow for liver disease. However, these type of programs, especially if you can integrate them into EMRs, electronic medical records, and so that and it's being done automatically in the background. Um, it provides an opportunity for primary care physicians to really identify people where these people live, essentially, which is in primary care, and then pick out the ones that are actually the ones that we're most concerned with from a liver point of view. Or it doesn't have to be liver, because of course all these type of programming, you can program just to identify people at cardiovascular risk, at a risk of developing a higher risk of developing diabetes. There's all of these different things you could program into there, and so it's actually I guess a way of thinking about using algorithms within a computer-based system to drive directing patients in the right way, so they get to see the right people. And so I think that's going to be a huge thing, because the problem is most of these patients are missed. I mean, if it's 25% of the adult population has NAFLD, and 2 to 3% has NASH. I mean, nowhere near that number are being evaluated for liver disease, and we all know that there's this huge group of people out there that I think primary care physicians and many physicians don't really know how to approach them. So this gives a tool, especially if it's simple, like an app is great. If it's embedded in the EMR, it's even better, because then it doesn't even require thinking. It just comes out and flags patients and saying, you need to be concerned about this patient potentially, or this sort of thing. I think that empowers family doctors and physicians in general to really, I think about people's liver disease when they might not be thinking at all about their liver disease. Actually, it doesn't even come into their sort of day-to-day thinking. They're busy practices, and you know, when you think of 2 to 3% of people have NASH, I mean and then there's going to be a subgroup of those that are going to progress to serious liver disease. I mean, a lot of physicians aren't going to spend a lot of time thinking about that because they're worried about the more common things that are coming into their clinic. And so they have a tendency to not necessarily have that on the forefront of their mind that, hey, this person has a BMI of 35, they're diabetic. I need to be thinking about other things. Our liver tests are abnormal. I've been watching them for the last 5 years. The platelet count's 130,000, and they don't think that that's necessary liver disease. And this is a way of saying, man, this person needs to see a specialist. So I think that's a huge leap forward. And then the second thing is, I'm very interested in what Mazen thinks of this. That I mean, a lot of these are okay. So we can use these type of algorithms to find these patients. We can then stratify them based on, okay, you're at higher risk or whatever, or you may have this degree of fibrosis already, and your increased risk over the next 5 years of progression to cirrhosis, say. So I think that's absolutely critically valuable. The second thing, of course, is that once these medications start coming on the market, a big issue is do these need to be lifelong treatments? So once we start to get into a course of treating patients, can we use these type of algorithms to predict when people can come off those medications, of course, which has tremendous cost savings with a disease that's so prevalent. I'd be very interested what Mazen thinks of that is that part of the long-term strategy? I'm sure it probably is, but
You were listening to our conversation just yesterday morning around the same time. Yeah, we were, I guess, taking it to the next level. As you know, right now, like things we talked about, and I'll make it brief. Things we talked about now, we have, for instance, American Gastroenterology Association algorithm that started with the FIB4, followed by a FibroScan. So one of the things that we are going to do is to compare these machine learning algorithms to that algorithm. As you know, FIB4 is a great start, but it does have a little bit downfalls, if you want to say. It does have, there are data showing that people in the indeterminate and low zone had some clinical liver events eventually. It does not perform as well in diabetics. But the start for comparison is just to see how many, because our cohort has biopsy, to see how many FIB4 followed by FibroScan will classify and misclassify compared to these algorithms. So that's the first step. We cannot do outcomes yet. The second step we talked about yesterday are therapies. So it will be easy to apply, right? We are not asking pharmaceutical companies to spend hundreds of thousands of dollars. Just apply the algorithm in your pre and post treatment responders and non-responders, and let's see how it looks like. So that will be another step. There are some drugs that we can test it. We probably go to some of these companies. And thirdly, actually, is comparing to outcome, which is much harder to do than your regular data sets. So a lot of data sets, they will have between 18, 20, 25 outcomes. And the New England Journal paper by the NASH CRN had 55 outcome. And they were following the patients for so many years, and they just got only 55 outcome. Machine learning, the problem with machine learning, they don't like small numbers. So if someone sends me a paper as AE to review and they did machine learning in 300-400 patients, I'll say, wait a minute, there's a problem, because the machine it will struggle with 300-400. Usually we look for 1,000 and beyond samples, and for outcomes, 20-25 might be an issue, unless if you've done some statistical methods where you kind of amplify the outcomes in your cohort artificially. It's okay, but it's not as good as when you have the real outcomes. So yeah, I give you the whole spiel about where we're going. We are going to compare it to the current algorithm, importantly, as you said, to see if it's going to predict a treatment response. And it might not be the same algorithm changing. It could be a formula that predict changes in the future, and looking at outcomes. It sounds a lot of formulas, but again, this is when you have you want to think about a robot doing the work for you.
Not sitting in your office, though.
Not or sitting in my office making my espresso.
That's right, the perfect robot. I think another powerful thing that Mazen touched on earlier as well is that so many different centers now are moving towards Epic-based EMRs, and Epic Epic is I guess is a way of thinking of, it's a common language that's going into these machines. Essentially, the variables can be. You can extract things out of the back end of Epic, which is like a giant electronic medical record, which has all of the different people that contact that patient go into that healthcare record. And so as we start to get more and more people using Epic, and more people then collaborate together, and Epic is spreading around the world. I mean, we're just undergoing Epic implementation here in Calgary, that are doing it in Toronto and Eastern Canada. So, and then throughout Europe, it's the biggest sort of EMR in the world, essentially, the way of thinking of it. And so it gives you an opportunity not only to collaborate with multiple centers, multiple different ethnic groups, multiple different countries, multiple different healthcare systems, but also it gives you a chance, I think, to just have the numbers can be vast, I think, as you start to expand that. And then you can start to, when you develop an algorithm, it becomes much easier, I think, to test it in those, when you have an Epic type thing, especially if they're linked centers where people are all on the same, thinking the same, they're interested in the same sort of things, where you can then apply it into with those huge groups of patients. I think it provides a tremendous opportunity to really shift the whole field forward, actually. I don't know, what do you think about that, Mazen?
Yeah, to your point, I mean, one of the things that we envisioned is you have a drug approved on the market, let's say resmetirom, and let's say I know you're very savvy in your system and you implemented screening for primary care and all this, but a lot of systems have not done that yet. And let me take the example, and I don't know what they did. I'm not saying they're not doing anything, but let's say Kaiser. And Kaiser all of a sudden is like, hey, we have drugs approved. We want to know how many patients we treat. So you can apply FIB4. It's usually going to ask you for F3 and more, and then you're going to do FibroScan on bunch. But also you can apply the NASH F2 formula and tell you have 3 million that they need treatment in your system. And out of those that many F2, that many F3, that you have to pay attention to them, and you have actually undiscovered cirrhotics that you need to screen them for HCC. So bring them to clinic and look at it, and that can be done. And once you apply for formula, less than an hour, and find out all these patients.
Yeah, it's a huge driver, and in fact, I think it'll be those type of groups that there's not only do they have a huge cohort of patients, but actually they're trying to do the best sort of therapy for those patients, but actually in the most cost-effective way. And so when you have that kind of it's almost like a business, it is a business model, essentially. I think that can really move change, because in the end, they want to do it cost-effectively. And so that drives people to look at things differently.
Indeed.
We're going to definitely have to have another call. We're out of time for this particular session, but I want to thank you for opening our eyes up, Mazen, to our future. And I know that we're going to have to do this again, because you're going to be learning on your own on top of the machine learning. So it's incredible. And Mark, thank you as always for sharing your input and insights as well.
Really great seeing you again, Mazen. It's always a pleasure chatting.
Same here. We have to do another trip to Europe, but to a safe country this time, Mark. Thank you for having me, Michael, and it was really a great pleasure.
Take care. Have a great day, everyone.
Take care, guys.
Bye-bye.
Bye-bye.